Lymphomas are clonal malignant disorders that derived from lymphoid cells, either precursor or mature T cell or B cell. Majority of a B cell origin. They are historically divided in two main groups. It's Hodgkin's lymphoma and non-Hodgkin lymphoma. But with the development of diagnostic technologies, lymphoma classification also evolved, became more complex. Today, morphology, immunophenotype, molecular, cytogenetics, and other techniques are used for diagnosis. The 2001 classification was rapidly adopted for clinical trials and successfully served as a common language between scientists comparing genetic and functional data. The new fourth edition of the WHO classification of tumors of hematopoietic and lymphoid tissues was published in 2008. It builds upon the success of the third edition, but recent studies have drawn attention to the biological overlap between classical Hodgkin's lymphoma and diffuse B-cell lymphomas. So current treatment guidelines are mainly based on serological markers. Course of the disease is very variable, but the prognosis has improved with modern treatment. Treatment generally depends on the aggressiveness of the disease, indolent, aggressive, or very aggressive. For Hodgkin lymphoma, almost 66,000 new cases are estimated to have been diagnosed worldwide in 2012. More than 25,000 deaths have been caused by Hodgkin lymphoma. Non-Hodgkin lymphoma occurs more frequently. More than 385,000 new cases have been diagnosed in 2012, and almost 200,000 deaths have been caused by non-Hodgkin lymphomas. The main feature of Hodgkin disease progression is continuous spread via the lymphatic chain, whereas heterogeneous group of non-Hodgkin lymphomas have unpredictable spread and more often are disseminated at the moment of the diagnosis. An ERBO staging is a staging system for lymphomas, both in Hodgkin's and non-Hodgkin lymphomas. It was initially developed for Hodgkin lymphoma, but has a use in non-Hodgkin lymphomas. It has roughly the same function as the TNM staging in the solid tumors. This classification was developed in 1971 and have four stages. The first stage is the involvement of a single lymph node region or extralymphatic site. The second stage is two or more lymph node regions involved, or an extralymphatic site and lymph node regions on the same site of diaphragm. Third stage indicates that lymphoma has spread to both sides of the diaphragm with or without focal extralymphatic involvement or a spleen lesion. And the fourth stage means diffuse or disseminated involvement of one or more extralymphatic organs, including any involvement of the liver, bone marrow, or nodular involvement of the lungs. So here we can see bulky disease. It's modifier X. It used if the largest deposit is more than 10 centimeters large, or whether the mediastinum is wider than 1/3 of the chest on a chest X-ray. Each stage may also be assigned A or B. The letter B is added if a person has any of the B symptoms listed below. There are loss of more than 10% of body weight over the previous 6 months, unexplained fever at least of 38.6 Celsius, and drenching night sweats. These symptoms usually mean the disease is more advanced. If a person has any of these, then more intensive treatment is usually recommended. If no B symptoms are present, the letter A is added to the stage. In both Hodgkin disease and non-Hodgkin lymphoma, imaging plays an important role, not only for primary staging, but for response assessment with the impact of therapy. Conventional assessment of nodal involvement by CT is limited by its low specificity in case of small nodes, especially in nodes less than 1.5 centimeters in diameter. Extranodal sites of involvement can be difficult to detect by unenhanced CT. Bone marrow involvement by CT is usually detected only on lytic lesions. That's why in 2007, new response criteria, PET in the aid of treatment was added. Adding PET to CT response criteria improves the accuracy of restaging. So reduction of the glucose metabolism is measured by PET component, and the tumor size is measured on the CT component. In retrospective analysis, FDG PET-CT with an accuracy of 94% was more accurate than conventional staging procedures, including CT and bone marrow biopsy. It is explained, including the fact that biopsy from default locations has a low sensitivity when the focal lesion type is present. Some authors argue that FDG PET-CT might even eliminate the need for bone marrow biopsy in the primary staging of Hodgkin disease because FDG PET-CT is highly sensitive and specific for bone marrow involvement. It's 92% and 90% respectively. But there is an internal struggle for clinicians between chemotherapy efficiency and toxicity. And the same situation we have as a radiologist. We had to reduce radiation exposure without damaging the accuracy of imaging. Several trials in early Hodgkin lymphoma were investigating if it is safe to reduce treatment in patients with good response on interim PET. Consequently, reduce the treatment toxicity. Conversely, researchers are interested and investigated whether survival will improve if therapy is escalated in poor responders with high-dose chemotherapy or early stem cell transplant. Nivelstein calculated a mean cumulative effective dose of 97 millisieverts in 2.5 years after diagnosis in adults with non-Hodgkin lymphoma being followed up with PET-CT. Effective dose for a single whole-body CT scan was about 13.3 millisievert, and FDG PET is 4.2 millisievert. So that's the cumulative radiation dose could be reduced significantly by replacing CT scans by MRI. Another important topic in a conversation about reduction of radiation exposure is pregnancy and lymphoma. The incidence of lymphoma ranges from 1 in 100 or 1,000 to 1 in 6,000 pregnancies. Hodgkin disease occurs in more cases. Non-Hodgkin lymphoma occurring in pregnancy is more rare. Here we can see the adverse effect of radiation in relation to gestation stage. From the second trimester, ABVD regimen chemotherapy for Hodgkin lymphoma and CHOP for non-Hodgkin lymphoma with minimal effects to the fetus can be treated. The only modality that can cover whole body for proper staging without damaging the fetus on pregnant lymphoma patients is MRI. Here we can see the woman at the 32nd week of pregnancy with stage 2 Hodgkin's lymphoma. Subsequently, this is a complete remission and normal delivery. Whole body MRI is currently of high research interest and might become a good alternative to CT. There is evidence that whole body diffusion weighted MRI with a sensitivity of 19% and specificity up to 94% could be as accurate as FDG PET-CT for the staging of lymphoma. MRI in a recent meta-analysis was almost equal sensitive to FDG PET-CT for the detection of bone marrow involvement in Hodgkin lymphoma, but was less specific. The addition of diffusion-weighted images significantly increased the accuracy of whole-body MRI for primary staging of lymphoma patients, leading up to 94% concordance with FDG PET-CT. But whole body MRI bears the risk of overstaging lymphoma, but never understaging. Particularly in small indolent lymphomas that are not considerably FDG avid, additional information may be gained from diffusion-weighted images. Here we can see 1.5 Tesla diffusion-weighted images with a b-value of 50 and b-value 800, and FDG PET images of 57-year-old patient with histologically proven concomitant diffuse large B-cell lymphoma and follicular lymphoma. Diffusion-weighted images helped to detect miliary hepatic lesions, while FDG PET shows only one equivocal focal increase uptake. The hepatic involvement was confirmed on the dedicated hepatic T2 weighted images too. Here we can see the patient with non-Hodgkin lymphoma. Bone-windowed coronal CT doesn't depict spread of paravertebral lymphoma masses into 12 thoracic and first lumbar vertebra, which are visible on a coronal FDG PET-CT. Coronal short tau inversion recovery MRI and coronal FDG PET-MRI better depict and confirm bone infiltration. MRI has high sensitivity for imaging of bone marrow effects in total and shows the first infiltration of plasma cells before overstimulating of osteoclast, and the resulting of bone destruction. Due to the lack of radiation exposure, MRI component or PET MRI may evolve as an alternative to PET-CT in potentially curable patients. Here we can see the contrast enhanced CT scan, showing a hepatic lymphoma manifestation before chemotherapy, and fused FDG PET MRI before chemotherapy with pathologically FDG uptake. Then this one we can see the residual mass on non-enhanced CT scan and corresponding PET MRI showing no pathological FDG uptake here. Meta-analyses have demonstrated that FDG PET and PET-CT have detected residual disease with up to 19% sensitivity and 91% specificity in patients undergoing classic chemotherapy. These imaging methods are predictive of progression-free survival. Negative FDG PET finding indicating a higher probability of progression of free survival. The available literature indicates that false positives are more often seen in rituximab-based chemotherapy. The positive progression value and negative progression value of the FDG PET CT for progression-free survival after completion of chemotherapy was 71% and 80% respectively in patients undergoing rituximab-based chemotherapy. For assessment of early interim PET, 5-point scale or DeVille criteria was developed. Third point is the borderline between negative and positive FDG uptake, but boundaries between these points are too blurred. As Regina Kluge from Leipzig reported on her recent speech, a semi-automatic method for estimating interim PET under development on the last stage. But meanwhile, with regard to this problem, MRI, especially diffusion-weighted imaging, can help in restaging of disease and evaluation of therapy response. Biophysiological information provided by diffusion-weighted MRI regarding the change of cellularity, tissue composition, and architecture after treatment will potentially be helpful in response assessment as compared with diagnostic CT or conventional MR examination. Here we can see the serial 3T ADC maps and FDG PET CT images on a baseline and during the chemotherapy for the same patient with Hodgkin lymphoma. The ADC of the right paratracheal nodal mass doubled from baseline to after 4 cycles of chemotherapy, indicating a good response to treatment, while stable disease was issued based on Jason's size criteria. Low residual FDG uptake was noted after 2 courses, which increased in intensity after 4 cycles of chemotherapy. But mediastinoscopic biopsy directly after the 3rd PET CT scan revealed no evidence of residual disease. Here we can see the PET MIP image showing enlarged lymph nodes with increased FDG uptake in the mediastinum and right axilla, inverted MIP of diffusion-weighted MR images with the lymphoma mentioned above, clearly recognizable here. And PET MIP after chemotherapy with the corresponding inverted diffusion-weighted imaging MIPs showing complete response. Here we can see the 70-year-old woman with lymphoma after 2 cycles of chemotherapy showing non-specific symmetric FDG accumulation in brown fat tissue, but if there is still an active tumor. 3 days after, examination was repeated with beta blocker that clearly revealed the residual tumor in anterior mediastinum. The use of PET MRI instead of PET CT in the surveillance of lymphoma patients undergoing chemotherapy may also be helpful for differentiation of thymic rebound from recurrent lymphoma of the mediastinum. Chemical shift MRI provides MR images with 2 different contrast in-phase and opposite phase images depending on the fat to water ratio. This technique by detection of the fat within a tissue mass allows for the discrimination of hyperplastic thymic tissue from tumor tissue. Benign hyperplasia has a chemical shift ratio lower than 0.75. But whole body MRI have some limitations. Here we can see the whole body FDG PET image in maximum intensity projection and 3T diffusion weighted images, including the ADC map of the 19-year-old patients with primary mediastinal B-cell lymphoma. Also, the diffusion weighted images were acquired under respiratory gating. The bilateral FDG avid diaphragm nose appear completely white on a corresponding ADC map. Probably this is related with cardiac motion or an lung susceptibility artifacts. Whole body MRI with breath gating is good enough for evaluating of focal lesions of the lung. CT compared to MR has the advantage of evaluating focuses less than 5.4 millimeters, which are not possible to differentiate between specific and post-inflammatory changes without any follow-up. Imaging modalities used in lymphoma include wide range from X-ray to whole body PET-MR. Each of them has its own advantage and disadvantages. CT maintains its position because of its wide distribution. PET-MR offers the unique opportunity to evaluate the differential and integral impact of diffusion-weighted images and FDG PET in staging and restaging of lymphoma. In general, PET-MR will be indicated and performed superiorly to PET-CT in those oncologic indications that need high soft tissue contrast. In indications in which soft tissue contrast is of limited importance, will probably remain the domain of PET-CT. So meanwhile, the PET-CT is remaining as a gold standard for diagnosis of lymphoma, and universal methods has not been found yet. Thank you for your attention. That's all.